Oncology Seminar. It is titled Epindymoma. It was presented by Dr. Diana Osorio on the 20th of August, 2018.
Hi, my name is Diana Osorio. I'm a neuro-oncologist here at Nationwide Children's, and thank you, St. Jude's, for this opportunity. Today we're going to be talking about ependymomas. So in general, the epidemiology of ependymomas, this is the third most common pediatric brain tumor. It comprises anywhere between 2 to 9% of all the pediatric brain tumors. And in children less than 3 years of age, it comprises as many as 30% of all CNS tumors. It can occur in many different locations. 2/3 of them actually occur in the posterior fossa and typically do not present with metastases at diagnosis. 25% of primary spinal cord tumors are ependymomas, and we're going to talk briefly about those later. The symptoms of how a patient would present if they had an ependymoma obviously depends on the location of where the tumor is. Supratentorial ependymomas typically present with motor deficits, sensory deficits, seizures, speech difficulty, or vision changes. It can also present with headaches, vomiting secondary to hydrocephalus, gait instability, or ataxia and papilledema. That's more if it's in the posterior fossa. And in the first year of life, you have to look for children who have increasing head circumference, developmental delay, or even head tilt, which would be more typical of the tumors presenting in the posterior fossa. The initial imaging and staging for the patients to determine the extent of disease, given that it can occur anywhere. Even if you have a primary brain tumor, you should always check the spine. And currently the standard of care is still to do the lumbar punctures for cytology. If there's a primary spinal tumor, we still check the brain to ensure there's no metastases to the brain. There are some genetic predispositions, but the one that's very important to note is neurofibromatosis type 2, where it's fairly common for patients to have primary spinal cord ependymomas. Ependymal tumors are in the WHO 2016 classification. There's ependymoma grade 2s and grade 3s. Ependymoma, the most common of the grade 2s is the cellular ependymoma. And then there's papillary, clear cell, and tanocytic, and I'm going to show a few pictures about that. Tanocytic is quite rare. Anaplastic, WHO grade 3 ependymomas are fairly common. Myxopapillary ependymomas are primary spinal cord tumors, and they're grade 1. And then subependymomas are rarely, if ever, seen in under 20 years of age. So it is not a tumor that we're going to discuss at all in this presentation. So in the WHO classification of tumors of the central nervous system, the World Health Organization, a very typical histological appearance of ependymomas are the ependymal rosettes here on the right, and they're characterized by columnar tumor cells arranged around a central lumen. This is a very diagnostic hallmark of ependymomas. I'm not a pathologist, but I just wanted to briefly show pictures for the oncologists. GFA positivity is also a fairly diagnostic criteria, and it's positive in the pseudo-rosettes. These are the different histological subtypes just to show how they can look very different, here being the cellular ependymoma. Now, what characterizes an anaplastic ependymoma from a cellular ependymoma is that you'd see more poor differentiation in mitoses and necrosis, and a higher proliferation index. And so it's important to note that over the years, the studies have not really confirmed a definitive association between the prognosis and overall survival based solely on histological grading. That is, between grade 2 and grade 3, they haven't noted a significant survival advantage. And it's partly due to the fact that there's some subjectivity in determining what is a grade 2 and grade 3. So now to talk about ependymoma depending on their location. So when we talk about posterior fossa tumors, it's below the tentorium versus supratentorial. And I just wanted to highlight that for the non-neuro-oncologists who may be listening to the talk. So the posterior fossa ependymoma is clinically very different from a supratentorial ependymoma, so I want that to be something that's very clear in this presentation. This is a very common MRI of a patient with a posterior fossa ependymoma. The tumor likes to extend to the cervical canal through the foramens. They just like to go through any hole that is available, and so that also presents a distinct surgical challenge. So as you can see here, it likes to extend into the foramen of Magendie, and this is also another classic presentation where the tumor extends into the foramen of Lucia, and it does enhance with contrast heterogeneously. This is a nice picture from the World Health Organization as well, showing how the tumor completely occupies the fourth ventricle. Now, along with the supratentorial ependymomas, they can look very different. Here's an example of one of our patients. And this is an infant with a supratentorial ependymoma. So can have a cystic appearance with a solid component. So they can have different presentations. And just briefly about myxopapillary ependymoma, this is actually my only slide on myxopapillary ependymoma. Symptoms for patients are they have back pain. These tumors are very well demarcated and circumscribed. They contrast enhance. The treatment is surgical management, and of note, they can metastasize along the spinal cord and into the brain. Therefore, you do need a full brain and spine MRI when assessing these patients. And lastly, like I said before, the surgical resection is the most important thing for these patients. And even with a partial resection, we would still observe these patients, not necessarily treat them with anything further, depending on their symptomatology. There has been quite a boom in the understanding of the molecular characteristics of many of our CNS tumors, notwithstanding the ependymomas. They have now classified these tumors into 9 different molecular subgroups, of which only 6 really apply to children, which I'll highlight in the next slide. It appears that molecular classification is superior to histology for prognosis. And supratentorial ependymomas are characterized by either RELA or YAP1 fusions in children. And this paper is very important, so I encourage people to look it up. So this is the slide that I was talking about, where we will just discuss the 6 subtypes that are pertinent to the pediatric population. In the spinal cord tumors, we have myxopapillary ependymomas or anaplastic ependymomas, the latter being more common in NF2 population. Overall survival from these two. This is the slide that I was talking about, where we will just discuss the 6 subtypes that are pertinent to the pediatric population. In the spinal cord tumors, we have myxopapillary ependymomas or anaplastic ependymomas, the latter being more common in NF2 population. Overall survival from these tumors are excellent. Now going on to the most common, 2/3 of the ependymomas are posterior fossa. We have ependymoma group A and ependymoma group B. And as you can see, the histology is not going to give you an indication as to whether it's going to be an ependymoma A or an ependymoma B. And the posterior fossa A tumors are more frequent in the younger pediatric population compared to the ependymoma B. And the survival analysis in this retrospective study is that the ependymoma A patients tend to have a worse prognosis. Similarly, with supratentorial ependymomas, we have YAP1 and RELA fused. Again, the histology is not going to be giving you an indication as to which one would be more likely. And it occurs anywhere in the supratentorium. The YAP1s and the RELAs, by age, you really cannot have a good indication as to which one it could be, as you could with the posterior fossa ependymomas. And I just want to caution people into looking at the survival analysis, because as we'll detail later, the YAP1 does show a better prognosis, overall survival. But just bear in mind that this is a retrospective study, And in the YAP1 group, there was only 10 patients analyzed compared to 70 plus in the relafused population. And as I was alluding to in the previous slide, this is a slide about the progression-free survival for posterior fossa ependymoma versus supratentorial ependymoma. There is a clear progression-free survival advantage to posterior fossa ependymoma B versus posterior fossa ependymoma A. There is a good number of patients in both groups. However, to recall, this is a retrospective study without a real understanding of the extent of resection of these patients and how they were treated. Therefore, it is information to be taken with caution, and to definitely these clinical trials need to be taken in a prospective fashion. Similarly, on the other side, with the supratentorial ependymomas, the YAP1 versus relafused, there is a progression-free survival advantage to the YAP1, but just note that there were only 10 patients in the YAP1 group compared to 79 in the relafused group. Management of these patients, this is the important piece that we want to talk about. What is the most important prognostic feature in any ependymoma, regardless of the location, is surgery. A complete resection is associated with the highest overall survival, irrespective of age, location, pathology, or treatment. And currently, what is considered a gross total resection is stricter than even our medulloblastoma patients, and it's a thickness or nodularity measuring less than 5 millimeters in its largest dimension. So surgery. Historically, a complete resection is possible, but not in all patients. So 42 to 62% of patients is an older study, and it is easier to obtain a complete resection in supratentorial ependymomas. I wanted to highlight here how complete resection with radiation provides a larger overall survival and progression-free survival at 5 years compared to an incomplete resection with radiation. And surgery alone, however, is not sufficient for cellular posterior fossa ependymomas in this older study from 2005 that showed that a complete resection alone gave a 67% 10-year overall survival versus a complete resection with radiation therapy gave an 83% overall survival in this patient group. Similarly, a partial resection with radiation only gave 43% 10-year overall survival, giving further evidence that complete resection is very important in this patient population. Surgery alone for cellular ependymomas, the local control at 5 years is also a lot higher when you have a complete resection. This is a compilation of several studies showing that overall 78% of supratentorial ependymomas achieved local control at 5 years with surgery alone, compared to posterior fossa ependymomas, where 58% achieved local control at 5 years with surgery alone. Therefore, showing how supratentorial ependymomas, there is a higher chance that this patient population can do well with surgery alone compared to their posterior fossa counterparts. And this is the clinical distinction we want to highlight in this presentation, that supratentorial ependymomas are clearly clinically different from the posterior fossa. So to treat the posterior fossa ependymomas, it's been shown with several studies over the years that you need both components at this moment in time, surgery plus irradiation. We know that in the future, given the better prognosis of the posterior fossa B, we're going to be looking into which patients can be treated without radiation. But that is still to come. So surgery. Given that this is a talk about how to best manage our patients, it's important to confirm the extent of resection with a postoperative MRI within 24 to 48 hours from surgery to avoid confusion with post-surgical changes seen on the MRI. So the general treatment strategy for all posterior fossa ependymomas is to first obtain a complete resection as best and safely as possible for the patients. And those children who are at least 12 months of age and older without metastases, those children, even though they are less than 3 years of age, can receive focal radiation to their posterior fossa. Given the location of the radiation therapy, we're going to go into that later as to why we do allow radiation therapy in children even less than 3 years of age. As long as they're older than 12 months, they can receive focal radiation. And the doses vary depending on their age slightly. And the goal is to start radiation therapy within 2 to 4 weeks from their surgery. And in children who are less than 12 months and without metastases, but had a complete resection, what do? You try to bridge them until they reach 12 months of age with chemotherapy. And there are a few regimens that we're going to discuss in this talk that we can utilize in the interim until we bridge them to get their focal radiation once they're older than 12 months of age. And posterior fossa ependymomas, I know that there's always talk about whether there's real metastases or not. And just for our viewers to be aware that metastases is most common at recurrence and not at diagnosis. So since this is a very rare scenario, we want people to be careful to not overcall radiographic and cytologic metastases in this patient population. And the concern is also if you had a patient with metastases, true metastases, the concern is that craniospinal doses are not high enough to be curative in this patient population. As you saw on the previous slide, that we go upwards of 54 to 59 gray to achieve cure. And the highest craniospinal doses we're allowed to administer are 36 gray. So what is the role of chemotherapy in ependymoma? It's very variable and it's usually transient. It's used in cases of incomplete resections and in children less than 1 year of age to delay radiation therapy, as we discussed previously. And the role of chemotherapy remains uncertain in the setting of a complete resection. And this is actively being studied in the Children's Oncology Group CNS 0831, where they are randomizing patients to receive maintenance chemotherapy and to see if there's a distinct survival advantage in giving chemotherapy. So to just highlight one more time what we do for our patients who have had an incomplete resection and they have a posterior fossa ependymoma, we do utilize chemotherapy to reduce the amount of residual before radiation therapy. At times, these are the two regimens that we have used in the past, the Garvin protocol and the ACNS 0831. Typically, we trial 2 cycles to see if there was a response by the tumor and whether it reduced in size and sufficient to receive radiation therapy. The goal basically being to be at minimal residual disease before we administer radiation therapy in these patients. So we therefore usually apply 2 cycles, reassess with an MRI, see if there was any response to the chemotherapy. So supratentorial ependymomas, as I have been alluding to in the previous slides, is that not all patients need radiation. All patients need surgery, and there will be studies in the future to determine, and there is an ongoing study with the Children's Oncology Group, where there is a subgroup of supratentorial ependymomas that do not receive radiation therapy. To give a little bit of a historical perspective, the ACNS 0121 had an observation only after a complete resection for patients with supratentorial ependymoma, however, only with the classic histology. And there were 11 patients. 2 recurred locally in the first 12 months. Both had salvage surgery and focal radiation and reported no evidence of disease after 30 months. The overall survival in this group was 61% at 5 years. Like we said before, the posterior fossa ependymomas had a progression-free survival where the overall survival was significantly greater, showing that they are salvageable patients. Another study by Venkatramani et al., published in the Pediatric Blood and Cancer in 2012, showed 10 patients with supratentorial ependymoma, and a median age of presentation was 5.6 years. Histology for these patients was 7 anaplastic, 3 cellular. The treatment was 6 complete resections. 5 had continued with observation and 1 with chemotherapy. So 6 of the 10 did not require further therapy. 4 had incomplete resection, 1 observed, 2 were radiated, and 1 had chemotherapy and radiation. So in this cohort of patients, there were 4 recurrences total, after which these patients received another surgery plus radiation. Some patients received chemotherapy and remained alive at the time of the manuscript. The study reports an 86% overall survival at 5 years and a 53% progression-free survival at 5 years. It's also important to note that 70% of these patients had anaplastic histology, which classically you would think would have a worse prognosis. However, what proved to show in this small cohort of patients is that this patient cohort had an excellent overall survival and very salvageable population of patients. The delays in therapy. Now we're going to discuss a little bit about delays in therapy, clinical studies, and neurocognitive considerations in this patient population. So delays in treatment will reduce overall survival. There was a study done by Paulino et al. In 2000 showing the time to radiation. If time to radiation was within 50 days from surgery, there was 5-year local control of 71% and a 5-year overall survival of 86%, compared to if there was greater than 50-day time to radiation therapy, there was a significant reduction in local control and overall survival in this group of patients. And this is especially important in this talk, given that delays in radiation therapy are not uncommon, unfortunately. And this is just a highlight of some of the treatment protocols that we've been using over the last several years, since 1976, showing the great improvement in overall survival, of which Dr. Tom Merchants has the best survival with an 85% overall survival in 5 years. This is also to demonstrate how focal radiation therapy was proven to be as effective as craniospinal irradiation in ependymoma, and is the reason why we do not treat with craniospinal radiation in this subgroup of patients. Here you can notice that craniospinal radiation resulted in 27% overall survival compared to 31%, and we'll go to the more recent one from Paulino in 2002 to a more recent one where CSI conferred a 71% overall survival compared to 81%, and similarly the Timmerman study showed a 55% overall survival with craniospinal radiation compared to 80% with focal radiation. And this is the slide that demonstrates how radiation therapy given focally to the posterior fossa does not confer a change in IQ in those less than 3 years of age, and this is why we justify giving radiation therapy in children over 12 months of age, given that we did not notice that a change in IQ in these patients. In comparison to craniospinal radiation, from this slide where you can definitely see a significant decrease in IQ as a result of craniospinal radiation, and this is why there's that cutoff in our medulloblastoma patients compared to ependymoma patients. So now to discuss a little bit about what are the treatment options during when a patient has a recurrence of their ependymoma. This is an active period of investigation. This is some general information about recurrences. When an ependymoma recurs, it typically does recur locally. Again, you have to stage your patient and make sure you get brain and spine MRI. Regardless, recurrent ependymomas are a therapeutic challenge, and optimal curative treatment is under investigation. Surgery plays, again, an important role even in recurrent cases and has a dramatic impact on prognosis. So prior to discussing irradiation, surgical resection of the recurrent tumor should be a high consideration if the child is in good clinical standing, and if this is feasible, if the resources are available for your patient to do so, it is an important consideration to attempt surgical resection. Re-irradiation after surgery, you can either consider focal or craniospinal depending on the extent of tumor. And we are still waiting to understand the long-term adverse effects, but given the dire prognosis in patients who have recurred, re-irradiation is one of the front lines of therapy in recurrent ependymoma. There is currently a prospective study for re-irradiation at St. Jude's with Dr. Tom Merchant. This is one of the retrospective clinical studies done by Dr. Tom Merchant, where he showed a survival benefit in recurrent ependymomas with re-radiation. Here's another study by Dr. Buffet in sick kids, where he showed that the re-irradiated patients had a significant overall survival advantage at 3 years compared to those who did not receive re-irradiation. The recurrence and re-irradiation, it's important to note that those who receive CSI may have a better survival advantage. Again, these are retrospective studies. The green line demonstrates those who had local failure and focal re-radiation and focal radiation. And the red line, it demonstrates the overall survival of patients who had received gamma knife, and therefore is one of the many reasons why we avoid gamma knife radiation in our patients. In summary, the standard treatment of posterior fossa ependymoma continues to be maximal surgical resection followed by radiation therapy. There is subjectivity in determining grade 2 versus grade 3 ependymomas, and it's therefore not a reliable prognostic indicator. Like we discussed, molecular biology of these tumors appears to be one of the better prognostic indicators going forward. Progression-free survival at 3 years reported up to 75% in ependymomas as a whole. But to remember that this is a group of patients that are likely to recur. But this lumps both ependymomas in the posterior fossa or supratentorium. Infants less than 1 year of age, focal radiation therapy is not accepted. As we discussed, you can radiate as early as 12 months. And remember that we can always use chemotherapy to delay the need of focal radiation therapy until they turn 1 year of age, or if there's sufficient time to discuss with your radiation therapist until they feel comfortable that they can do the proper therapy for the child. There is still consensus for treatment of recurrent ependymoma still under investigation. However, the prognosis for patients who have recurred is quite poor. And given this talk, I thought I would take advantage and discuss just a proposal for low middle income countries to work with their local policymakers or health insurance companies, however each independent country works, to centralize the patients with a suspected posterior fossa tumor that could be an ependymoma or medulloblastoma, to centralize the patients to centers with experience in pediatric neurosurgery with the equipment necessary to perform the best surgery possible for these kids, given that we give them the best survival advantage if we obtain the best surgical resection possible at diagnosis. Never forget that working with your team, with all the disciplines involved with any patient with neuro-oncologic tumor, it's important to work as a team. The multidisciplinary team effort, it definitely contributes to better patient outcomes. And let's work on eliminating those treatment delays, understanding what are the next steps in the management of our patients so that we can get things moving as soon as possible and avoid delays in treatment. Lastly, I wanted to just let everyone know about our Latin American Brain Tumor Board, where we discuss patients only with brain tumors from Latin America. We discuss our cases mainly in Spanish. Brazil, sometimes we do them in English and translate to Spanish. So everyone is welcome. Feel free to email me if you're interested in participating. These are unique and individual patients, and their treatment programs may be individualized, so it's important to have a discussion about the patients, and we find that it's helpful to discuss it as a group and figure out the best way to treat the patients going forward. This is the primary team of global neuro-oncologists that participate in the panel. Thank you very much for your attention, and speak to you soon. Thank you.